Hello to everybody. I think I know some of you. Obviously, I know Jeff really well. Today we'll talk a little bit about pneumocystis, and I think Liz is going to present a case. I've been working with this disease since 1983, when I first started working with HIV. And it's been a very interesting ride because I've seen a lot of changes in the management. And it was, I guess, when we started using the steroids, we saw some incredible responses, which we were not seeing, with some of the sicker patients. And the sad thing is, you'd think you wouldn't see this anymore, but we're still diagnosing in Macon, Middle Georgia, and the southern part of Georgia where I work also, probably about a case I'd say maybe every 2 months between the ID physicians I work with. So it's still an issue, but and mostly people that come in late that have not been diagnosed or they've gotten off therapy, which we're still having issues with. The infection is something that occurs early in childhood. And when they first documented this infection in humans, it was back in the 50s when there was a number of children that were seen with this in Eastern Europe in orphanages. And they attributed this to malnutrition in these kids. They tried using the antibody test, but most of these kids were positive. So it really wasn't, in retrospect, it was not a optimal way to diagnose these patients. And the really true cases were mostly diagnosed at autopsy. We now know this is an airborne disease. In some patients, it may be a new acquisition of infection, but or for the most part, most of us believe it's a reactivation of latent infection. The data for new acquisition was in situations where people in the same setting had the same organism when they would look at it from DNA genetic analyses of the organisms. The majority of patients that have developed this infection disease are those, of course, with low CD4 counts. Other factors that are associated with it as well are those who have low percentages of CD4s, less than 14%. They've had previous episodes of pneumocystis. They've had thrush, recurrent bacterial pneumonia, unintentional weight loss, and higher plasma levels of HIV and RNA. I do want to mention that, we'll talk a little bit of this at the end, at some of the times when we have patients with pneumocystis who are not responding, or people who have quote-unquote other types of pneumonia that aren't responding, may have concurrent pneumocystis or CMV with pneumocystis or some other infection. We've seen everything from histo to crypto as well as CMV, probably the most common thing, concurrently with pneumocystis. So when you see a failure, consider other co-infections. There is a subacute presentation in most of these patients, and you'll see them come in. I've been short of breath for 2 or 3 weeks. They'll have a cough. The vast majority of the time is non-productive unless they have a co-infection, obviously. And they have sometimes chest discomfort with fever. One of the most common complaints I see sometimes is they can't take a deep breath. They take a deep breath and it feels like it just stops, and especially as the disease progresses. The physical examination can be completely normal, and this is what often throws people off. We've had several people diagnosed with quote-unquote asthma despite the absence of any wheezing. These are usually females that were not at quote-unquote considered high risk for HIV. This disease wasn't considered until they came in extremely late. One of them, in fact, died. And again, was just given the diagnosis of asthma. Because the lungs were normal, no one did a chest x-ray. And of course, early on, the chest x-ray itself can be normal in these patients. Extrapulmonary disease is quite rare now. I've not seen any cases since we quit using aerosolized pentamidine in this area for pneumocystis prophylaxis. And I believe the last one we saw was in the muscle, and that was probably back in the early 1990s. Diagnosis, again, you have a high degree of suspicion when you get the history, as I mentioned above. A blood gas is often very helpful in these cases. If you see a low PO2, obviously in a patient that's especially a non-smoker with HIV or at high risk for HIV, then you must consider the possibility that widened AA gradient is very helpful. The easiest thing, if you want to just ballpark it, if they have a low PO2 and a low PCO2, consider the possibility of pneumocystis, especially if they have the classic chest X-ray. But again, the chest X-ray can be completely normal early on. And when I say a low PO2, I've had people with PO2s as low as high as 90, and still they get to non-smokers. So you must always consider this as a possibility. Oxygen desaturation with exercise, again, is abnormal, but again, nonspecific. LDH is also a very nonspecific test, but helpful. Often you see this in the high 200s, 300 range. When you start to get in the higher levels, you have to consider other possibilities, especially over 500. You have to consider things like lymphoma. There's a mistake on the slide. It should be 1,3 beta-D-glucan is a component of fungal walls that can be elevated in pneumocystis. The assay, however, can be positive in other fungal infections. And we've used it several times more recently, and where the test has been negative, and the patients have had a moderately elevated LDH and turned out not to have pneumocystis. So a negative beta-D-glucan sometimes can be of help, especially if it's negative. Or positive again, but it's not specific. The chest X-ray, again, the one on the left is a patient with pneumocystis, is completely normal. The classic pattern is the bilateral interstitial pneumonitis that you see in the one on the right. If you did a CT scan of the one on the left, you'd probably would see changes. In fact, most of those patients do have changes. So again, even though the chest X-ray is normal, so that may be of help. It's usually a ground glass appearance on the CT scan. Atypical presentations, however, also occur depending on underlying diseases. If they have underlying emphysema, you may see atypical changes, atypical presentations. They may have nodules, blebs, cysts. Probably the most common thing I see is pneumothoraces in these patients. They present with pneumothoraces, and again are the atypical chest X-ray findings in people with underlying lung disease. But when we see somebody with spontaneous pneumothorax in the setting of HIV, we always consider pneumocystis. The presumptive diagnosis is based on clinical, the history, and the physical. You may induce sputum with some saline. In our hands, it's not been very good unless they've had overwhelming disease for the severe disease. Bronchoalveolar lavage, the BALs have been the most helpful as far as getting a diagnosis. Very few of our pulmonologists are willing to biopsy anymore. And again, the high index of suspicion is always there. If they're very severe, they end up on a ventilator. A mini bowel can be very, very helpful. And also, if you're doing this, and again, if that's severe, I always look for other pathogens. And again, the most common one we pick up is CMV. There was some debate several years ago, well, probably longer than that, from a Dr. Massour, who stated that the CMV we were seeing in these BALs were commensals. And one of the debates came up with the IAS meetings where one of the investigators that were there stated, well, asked him directly, do you still hold of this? And he said yes. And he then confronted him. He said, well, we followed your advice, and when the patient died, the autopsy showed he definitely had CMV pneumonia. So if I have a failing patient and I see CMV in the BAL, I'm going to treat that because, again, I've seen enough failures, enough progression of disease, and only with treating the CMV have they been proved. The prophylaxis for pneumocystis is started with CD4 cells less than 200, or if they have a history of oropharyngeal candidiasis, or low percentages of CD4s less than 14%, or other history of AIDS, other AIDS-defining illnesses that, but they may not qualify for pneumocystis prophylaxis. The initiation of chemoprophylaxis between 2 and 250 should also be considered if in settings where you cannot get frequent monitoring of the CD4 cells at least every 3 months. patients receiving pyrimethamine sulfadiazine for treatment of or suppression of toxoplasmosis will not require the addition of pneumocystis prophylaxis with other agents, because that will also cover the pneumocystis. The current medications that we're using, and for the most part, are the trimethoprim sulfa, the DS tablet once a day. However, you can also use a single strength in patients that can't tolerate the double strength tablets, or you can use the double strength tablets 1-3 times a week. The good thing about the trimethoprim sulfa, it also confers protection against toxoplasmosis and many respiratory bacterial infections. Alternatives are dapsone. I use a lot of dapsone in G6PD normal patients with G6PD levels that are normal that have kidney disease. It's much cheaper than the atovaquone, so you'll see me use a great deal of that in that patient population, which we see a good bit of kidney disease in our patients, especially where I work. Other options would include dapsone plus pyrimethamine plus leucovorin. The aerosolized pentamidine with the Respigard 2 nebulizer, which again we don't use anymore, at least in this area. I know they were using some up in Atlanta. Atovaquone, if they cannot take the Bactrim or the dapsone. The only problem with this is it's expensive, and some people just really can't stand the taste of it. Patients that are seropositive for toxo who cannot tolerate the trim sulfa. Alternate recommendations include the dapsone plus the pyrimethamine plus leucovorin, or the atovaquone with or without the same, with the pyrimethamine plus leucovorin. You can discontinue the primary pneumocystis prophylaxis once the CD4 count reaches 200 and above for over 3 months. And the prophylaxis should be reintroduced, of course, if the CD4 count drops below 200. There was a study that was quoted in the current guidelines that talked about patients who had low viral loads, whose CD4s were between 100 and 200 cells, who were not placed or had a stop pneumocystis prophylaxis, and there appeared to be the incidence of pneumocystis occurring was extremely low. So in these situations where, again, you have people having trouble tolerating the drugs, and you do have CD4s less than 200 but above 100, you may want to consider, not if you can't get a hold of the atovaquone or other options, that the risk of developing pneumocystis is relatively low, and just monitor them off of the pneumocystis prophylaxis. Excuse me. The treatment of the pneumocystis, as we mentioned earlier, if you're going to do this as an outpatient, if they have mild disease, trimethoprim sulfa is a drug of choice. They mentioned modifying this for abnormal renal function because I've seen enough toxicity with abnormal renal function. I usually steer clear of this and go with atovaquone, but you could definitely do this if you monitor them closely. It is in the hospital. This is the drug of choice. We use between 15 to 20 milligrams per kilogram per day in 3 divided doses and again, we have very good responses in the majority of these patients. There have been some mutations that have been documented with resistance against sulfa drugs, but there's really no data clinically on how this is going to impact on the patient, and there's no way to really test this that I know of any of the centers in the state. Alternative therapies are dapsone plus trimethoprim. The most common one I use is primaquine plus clindamycin, especially in my patients that cannot tolerate the trimethoprim sulfa. Atovaquone suspension is the same dosage used for prophylaxis, but you give this, instead of 1,500 daily, you give 750 BID. And again, it's only used for mild to moderate disease. And again, it's very important to be cognizant of the fact that if they've got G6P deficiency, which we check every one of our patients for, you can have problems when you use dapsone or primaquine in these patients. And if it's severe, sometimes even trimethoprim sulfa. Patient with documented suspected pneumocystis with moderate to severe disease, room ARPO2 less than 70, or a widened A gradient, they recommend adjunctive corticosteroids. And the guidelines, what we use here in Macon is prednisone. We 40 milligrams BID for the first 5 days. We cut it back to 60 and then down to 20 over the 21-day course of therapy. This was a dramatic finding. I can remember being called from one of my colleagues in Athens when we first recognized this. It was before it was published, and to see very ill patients with pneumocystis who invariably died despite adequate treatment, they all survived. There's been some debate about what it's really doing. People said, well, it's decreasing the inflammation, but really there's not much inflammation going on, obviously. But it may be, in fact, impacting on their adrenal function, because as you know, about 1/4 of all patients with late-stage disease will have adrenal insufficiency to some degree. So we may, in fact, be treating the adrenal insufficiency in these patients. And again, if you can't use the prednisone, you can use IV methylprednisolone, or I've even used hydrocortisone in these patients, IV. Patients that are diagnosed with pneumocystis, it is ideal to begin highly active antiretroviral therapy within 2 weeks of the diagnosis. The survival has been is definitely better in these patients. You may have some immune reconstitution issues, and sometimes even without that, you'll see when you start treatment, even without the steroids or the ART therapy, you might even see a decline somewhat early in the treatment, maybe in the first day or so, but then they'll improve. But the initiating ART early has dramatically improved survival in these patients and outcomes. Secondary prophylaxis, again, is the trimethoprim sulfa, just as in the primary prophylaxis we mentioned above. If they're intolerant to this, the dapsone, the etobicoline, aerosolized pentamidine. When to stop secondary prophylaxis, the CD4 count, of course, increases to greater than 200 for greater than 3 months as a result of ART, and it should be reintroduced, of course, if it drops to less than 200. There are some who feel that if an episode occurs at a CD4 count above 200, despite how high the CD4 count rises in the future, that they should have pneumocystis prophylaxis for life. In all my years of managing this disease, I've never had a situation like this, but again, that is the recommendation. So in conclusion, it's still seen. I'm sure some of you are probably seeing it in your area as well, because people are presenting so late. And I think having a high index of suspicion if someone's presenting with, new onset of dyspnea and exertion should really key you into looking for this and diagnosing it earlier, of course, before it gets into severe stages, really improves outcome as well.
I'd like to add one thing while we're still recording. This is Dr. Livingston. I think the diagnosis piece is kind of two things. One is making sure you're looking out for pneumocystis, and the other is making sure you don't just assume things are always pneumocystis. And so from the outpatient setting where most of you guys will be, you may have someone in the early stages of pneumocystis pneumonia who has no hypoxia at rest, their lungs are clear, they just have some dyspnea, they just have some cough, maybe some fever. And if you're not thinking about it, you won't catch it. A lot of times with those patients, we'll walk them down the hall, make them walk about 200 feet, check an O2 stat, and lo and behold, they drop down to 88%, or they maybe even drop down to 82%. And that's a pretty good indicator that something serious is going on in their lungs, and there's not a lot that presents that way besides pneumocystis. Certainly you're wanting additional diagnostic information to look at other things. And you don't want to do too much empiric treatment of pneumocystis. When possible, you want to diagnose it. There are rare cases where we're treating empirically, but most of the patients you're worried about, they have low CD4, they could have other pulmonary pathogens. what if they had TB? What if they had a fungal pneumonia, which sometimes happens, and you're giving them Bactrim, which isn't helping them, and prednisone, which might be making them worse in some cases. So in general, you want these folks to have an inpatient evaluation with rare exceptions. The other thing is, even if you find PCP, as Dr. Kantner said, there may be other infections present at the same time that you wouldn't want to miss, like TB or CMV. So it can be a kind of tricky diagnosis because we're working with a lot of imperfect tests, and you really want to think at the offset, how likely is it for this person to get PCP? If they're on Bactrim prophylaxis, that makes it a lot less likely. If they've been on ARVs successfully for 6 months or more, that makes it a whole lot less likely as well. And also, is this a subacute presentation? A bacterial pneumonia should be pretty acute. So sometimes you can differentiate and spare having, sometimes this gets over-treated empirically in the setting, in resource poor settings, I think. But you want to kind of put all those features together to make these decisions and run it by a colleague, because these can be tricky cases.